Hello, and welcome to the Fertility-Sparing Treatment for Gynecologic Cancer recording. I'm Aisha McClellan, the Cervical Cancer Program Coordinator at SHARE. For more information about upcoming webinars, support groups, and our helplines, please visit our website at sharecancersupport.org. Today, we are speaking with Dr. Mager. Before we begin, I'd like to hand it over to Dr. Mager to introduce herself.
Thank you so much, Aisha. I'm so happy to be chatting with everyone today about fertility-sparing treatments in gynecologic cancers. I myself I'm a gynecologic oncologist at Roswell Park Comprehensive Cancer Center, and this is a real area that I'm very passionate about. So with that, let me just share my slides here, and we'll jump right in.
Okay.
All right. Great. So infertility is a very common short and long-term side effect of cancer treatment for many cancer types. And we know from multiple studies that fertility and preservation is incredibly important to young people who've been diagnosed with cancer. Additionally, infertility is an important aspect of both their care and their survivorship. And infertility is associated with psychosocial distress following treatment for cancer. The majority of patients have expressed that they would prefer to have biological offspring above options such as adoption or third-party reproduction. So important to have that discussion early on in treatment course to talk about priorities and then to talk about options. ASCO is our large national organization that sort of governs clinical oncology in the United States. And ASCO has released this what I find powerful statement in their policy brief on fertility and cancer treatments. And they say ASCO considers fertility to be medically necessary care for individuals undergoing cancer treatment, regardless of their economic or insurance status. And I think that's something that should really guide the way we approach this for everyone. So it's important for oncologists to address the effects of treatment on fertility and to counsel patients if any fertility-sparing treatments are available. And patients undergoing treatment for non-gynecologic cancers are also impacted, but of course our focus today will be gynecologic cancers. So when we think about, let me advance these slides. All right. So when we think about gynecologic cancer and fertility, gynecologic cancers affect the uterus, the cervix, shown here, the ovaries, the fallopian tubes, and the vagina. The diagnosis of cancer in these areas alone can impact fertility even before treatment has begun. But most of the treatments for gynecologic cancers will have a significant impact on future childbearing. So let's jump into cervical cancer first. Cervical cancer is one of the most common cancers diagnosed in women under 40 years old. Luckily, in the United States, we've seen cervical cancer rates decreasing and also have found we've been able to catch it at earlier stages. But we still have cases of cervical cancer in the US and still important to address this. So hysterectomy is your standard approach, and hysterectomy means removal of the uterus and cervix. Sometimes I think there's some confusion around the terminology there. So hysterectomy is removal of the uterus and cervix. That's a total hysterectomy. Removal of fallopian tubes and ovaries is called a bilateral salpingo-oophorectomy, which is a little bit of a tongue twister, but actually not included when we talk about hysterectomy. Hysterectomy is uterus and cervix. So hysterectomy is the standard approach for early stage disease, but for women who desire fertility, there are options that can allow for retention of much of the cervix or the top of the uterus, which is the area where a pregnancy is carried. So the mainstay of fertility-sparing treatment for cervical cancer is something called a cold knife cone biopsy. So the cervix is a structure that's essentially a tube. And when we think about cervical cancer occurs on the outside of the cervix, so sort of in this outer portion, or along the lining of the tube. And a cold knife cone biopsy means removal of the abnormal area of the cervix, whether it be on the outside or along the lining, as well as a margin of normal tissue. So you do this sort of triangular shaped biopsy or removal of tissue from the cervix. This can be performed in select patients who have either what's called in situ disease, so disease where the cancer cells have not invaded yet, or in early stage invasive cancer. What are the impacts of this? So the most common thing we see is something called cervical stenosis. So again, going back to the nature of the procedure, this lining of the cervix is an area where you're operating. And so you can get scarring here. And that's what stenosis is, sort of closing off of that tube. That can impact ability to become pregnant, although certainly does not mean that one could not become pregnant. The next things we think about are in the event of a pregnancy, what are the impacts? So you can have an increased risk of second trimester loss, although the risk remains low overall, and an increased risk of preterm delivery, so delivering a viable pregnancy early. Now, ranges vary, but in the United States in general, your risk of preterm delivery for the whole population is about 10%, varies year to year. And cold knife cone, or what's called an excisional biopsy, which is what a cold knife cone is, can increase that risk by a couple of percentage points, usually between sort of 1 to 3 percentage points. All right. Now, what about for women who have more advanced disease at the time of diagnosis or more high-risk disease? There is a procedure called a radical trachelectomy, which is essentially removal of the entire cervix. And I'll show this a little more in depth in a moment. But it can be considered with women with a slightly more advanced but still early stage disease. Fewer patients are requiring this as we have more and more data suggesting that cold knife cone is safe in a larger group of women. So what are the criteria we use for assessing whether somebody is eligible for a radical trachelectomy? Tumor has to be less than 2 centimeters. They have to desire future fertility and have no evidence of impaired fertility. You want to have low-risk cancer types. And so these are your most common cancer types, which is squamous cell cancers, adenocarcinomas, or adenosquamous carcinomas. No evidence of metastatic disease. The cervix has to be long enough to remove a portion, so 2 centimeters or larger on the cervix. And you generally want age under 40, although I put an asterisk here because I think that is variable. That relates to this idea of no impaired fertility. And I think we know that there are options even after the age of 40 for having good ovarian function. We'll talk about that in a little bit. So what is the radical trachelectomy? So again, I showed a picture earlier of the uterus, the cervix, the fallopian tubes and ovaries. In a radical trachelectomy, you're removing the entire cervix. This is the cervix, a little bit of the top of the vagina, and then this tissue to the sides of the cervix called the perimetria. At the time that you remove that, and then you leave the uterus, the rest of the uterus in place, you place a little stitch at the bottom of the uterus called a cerclage. And essentially, that's something that can give additional support in the event of a pregnancy to sort of keep the pregnancy inside the uterus, so to speak. This has been performed through a vaginal approach, a laparoscopic approach, and an open cut, or what's called an abdominal approach. And how do women do? So the outcomes are excellent. This slide's sort of data heavy, but I just want to highlight a couple things on here. So a big question is always, if I do fertility sparing treatment, will I live the same amount of time? Will I do as well? And I want to highlight here. So this is looking at outcomes in radical trachelectomies and your 5-year overall survival, regardless of approach of surgery, vaginal, abdominal, or laparoscopic, is about 98%, 97, 98%. So these women are doing incredibly well and living very long lives. The other thing to note is the pregnancy rate, which is about 24%. Many women who have fertility sparing treatments for various reasons do not go on to attempt pregnancy. And so when you look at the overall rates, they seem low. And we'll touch on that in a moment. But if you look at this, live birth rate among those who became pregnant was 75%. So outcomes are good. Do you want to highlight, though, that 30% had preterm delivery? The majority of these are what's called late preterm, so almost full term, and still within sort of a safe range, although highlights the importance of working with a high-risk obstetrician or a maternal fetal medicine specialist, those are the same thing, in a pregnancy following a trachelectomy. So among women who do attempt pregnancy following trachelectomy, 70% were able to conceive, which is great. There is a higher rate of second trimester pregnancy loss. We talked about this, higher rate of preterm delivery. And very important to note that with a prior trachelectomy, women do have to undergo a C-section for delivery. Okay, so moving on to endometrial cancer. Endometrial cancer is cancer of the lining of the uterus, and this is most commonly diagnosed in postmenopausal women, and it is your most common gynecologic cancer. It tends to impact young women less, but about 5% of cases are diagnosed in women under 40, and we see that number going up, actually, nationally. So standard treatment is total hysterectomy and removal of both ovaries and fallopian tubes. However, there are women who are candidates for fertility-sparing treatment. And when we think about fertility-sparing treatment in the world of uterine cancers or endometrial cancers, it's really, can we preserve the uterus itself? And so women who have low risk uterine confined disease can be considered for fertility-sparing treatment. And these are sort of the broader criteria we use. The tumor is confined to the uterine lining or the endometrium. It's a low grade, so sort of non-aggressive tumor, FIGO grade 1. The patient has no impaired fertility and desires future fertility. An example of that would be somebody who already had premature ovarian failure, right? So in that patient, you just want to counsel about it, right? Are they planning on did they freeze eggs? Are they planning on doing egg donation, et cetera? So that's what we mean when we talk about impaired fertility. And are they able to receive hormonal therapy? So the hormone that we use here is progestin. These cancers are generally stimulated by estrogen. And when we use progestins, it can cause regression of the cancer. How do we approach this? So the basis, again, for fertility-sparing treatment is progestin therapy. We used to give it orally. Now we have progestin-releasing IUDs, and the one that the most data is around is the Mirena IUD. So that can be used instead of oral, and sometimes we combine the two, an IUD and oral medication. So you begin your progestin treatment, 3 months later, have repeat sampling of the endometrium to see if there's been any regression of the cancer. On average, it takes anywhere from 6 to 12 months to see regression of the cancer or clearance of the cancer. After 12 months, if there has not been clearance of the cancer, it would be a discussion with your gynecologic oncologist regarding next steps. What about ovarian cancer? Ovarian cancer occurs less frequently in younger women, but there are some ovarian cancer types that we do tend to see in younger women. Fertility sparing can be considered in early stage disease, particularly in specific subtypes like a malignant germ cell tumor, a sex cord stromal tumor, and tumors of low malignant potential. These are your less common ovarian cancer types, but again, more common in younger women. How do we approach fertility sparing here? So typically it involves removal of the affected ovary, so the ovary that's been diagnosed with cancer, but leaving the uterus, the cervix, the other fallopian tube and ovary in place as appropriate. Additionally, staging procedures often involve taking biopsies around the lining of the abdomen or assessment of lymph nodes, and that would really be something you discuss in conjunction with your GYN oncologist based on your exact diagnosis. Important to note that this should really only be considered after you've had a careful counseling around risk of recurrence and need for any further treatment after surgery, so radiation, chemotherapy, et cetera, and really needs to be tailored to the diagnosis and what the presumed stage is. Now, I'm going to discuss two techniques that are, I would say, newer and still sort of evolving in terms of their role. The first is uterine transposition. So uterine transposition involves essentially detaching the uterus, the cervix, from the top of the vagina. Ovaries and fallopian tubes are left in place, but you detach the uterus and cervix from the top of the vagina and then flip it up into the upper abdomen and actually attach it essentially to where the belly button is, the umbilicus. And in doing that, you move the uterus, cervix, as well as the fallopian tubes and ovaries sort of out of the pelvis. Now, this was first reported by a Brazilian group in 2017, and it was presented at the Gynecologic Oncology National Meeting. And this was performed in a 26-year-old who had a diagnosis of a rectal cancer and was planning to undergo pelvic radiation as well as a rectal resection. Pelvic radiation would have rendered the uterus, the cervix, as well as the ovaries non-functional, so they were moved up and out of the pelvis and then reattached following treatment. Now, this procedure has been done multiple additional times by the Brazilian group, as well as some areas, some other groups internationally and in the United States. Pregnancies, as well as live births, have been reported after this procedure. The Brazilian group reported a series of 8 patients, and 2 went on to have pregnancies and live births following the procedure. This is generally being done in the setting of people diagnosed with colorectal cancers. There have been a couple of reported cases of this being done in the setting of some gynecologic cancers, but I think we really need a lot more data there before we can say that it's safe from a cancer standpoint to do that. Now, uterine transplantation. This is something that was developed in Sweden, and it was developed sort of in the setting of not being able to use gestational carriers. And a uterus was either donated from a live donor or from what's called a cadaver, and then implanted into a somebody who either had a non-functional uterus or had their uterus removed. So the majority of patients have congenital conditions that resulted in a non-functioning uterus or absent uterus. And so we have more limited data in the setting of women who had a cancer diagnosis previously. There are a couple of reports of women who had sort of a history, a remote history of a cervical cancer diagnosis. Having uterine transplantation, but I would say, again, this is an area where we need a little bit more data before using it in the setting of GYN cancers. All right, and that's a note about assisted reproductive technology. I think this is really the key to everything. So assisted reproductive technology, I think also, sort of more casually called fertility treatments, is incredibly important. It offers options for fertility preservation, both when you're doing fertility preservation techniques with your gynec, as well as in the setting where it's not possible. And so options that, that you always want to have in mind are oocyte cryopreservation, also called egg freezing, oocyte donation or use of donor eggs, and a gestational carrier, also called surrogacy. Really important that all fertility options are discussed prior to initiation of treatment. So once you start treatment, the treatment itself can have that impact on fertility. So important to think about it before. Egg freezing should be performed prior to surgery, chemotherapy, and radiation. And really a timely referral to a reproductive endocrinologist is incredibly important. So seeing them sort of right at the time of diagnosis, and also working with reproductive endocrinologists who have familiarity with what we call oncofertility. So working with people who have been diagnosed with a cancer and sort of working around treatment. So to sort of summarize what we've talked about, fertility is an incredibly important part of cancer care. Loss of fertility has negative impacts on young cancer patients within the gynecologic cancer world and in the broader cancer world. And so important that we address it. And fertility-sparing options are available for some women who've been diagnosed with gynecologic cancers. Thank you.
Thank you so much for this wonderful presentation. I personally learned so much, so I greatly appreciate it.
Pleasure.
Yeah, so we have a few questions.
Yeah.
So we received some questions from our gynecologic cancer community, and so we'll just get right into it. What are the effects of immunotherapy on fertility?
Yeah, so immunotherapy is a sort of newer category of cancer treatment. And if we think about, when we think about cancer treatment, the majority of cancer treatments um, sort of attack the cancer cells directly. The way immunotherapy works is that it teaches your immune system to recognize the cancer cells and kill them. And so, as it's a newer type of treatment, I think the data around this is evolving. As best we know right now, it does not have a significant impact on fertility because it is not directly impacting cells itself, right? It's training your immune system to recognize cancer. That being said, I think as we sort of move along and use immunotherapy more, we'll have a better sense of more long-term outcomes with it. The one thing I will say is that it is not something that currently we recommend using in the setting of pregnancy. So some treatments can be utilized, in the setting of pregnancy, and right now that is not recommended. But again, I think data is evolving around this, but as of right now, we don't see any clear impact on fertility with immunotherapy.
Okay. Okay. Can you speak about ovarian and uterine transposition? When are they appropriate and how effectively they preserve fertility?
Yeah. So again, they're I would say more used in the setting of, let's talk about uterine transposition. So uterine transposition generally is used more for women who have been diagnosed with non-gynecologic cancers. Again, rare case reports in using it in certain cervical cancers, et cetera. But I would say we need a lot more data before we can say that's safe. In terms of the setting of somebody, let's say, who has a rectal cancer, so people who are getting a pelvic radiation for a non-GYN cancer, it has the potential for efficacy, although still not incredibly high rates. So the biggest series, or one of the larger series that's published, is from the Brazilian group who first did the procedure. And again, they reported 8 patients, and 2 were able to go on to live birth.
Mm.
So I think as more centers are doing this procedure and as we refine the technique, that success rate will probably be going up. But right now, I would say limited. It is effective for some women, but the majority will likely not go on to pregnancy for various reasons, right? And some of that may be just not trying for pregnancy after.
I see.
In terms of ovarian transposition, so ovarian transposition, again, is just preserving that ovarian function. And so we do that both for hormonal function to allow women to not have to go through menopause, which doesn't necessarily, it's not fertility related, or to keep the ovaries functional for subsequent egg freezing, because it's done in the setting of pelvic radiation. So usually the uterus or cervix is going to be impacted by that, right? So that's really what it's for. And ovarian function is maintained in about 90% of women who undergo ovarian transposition.
Can fertility-sparing hormonal treatment cause or increase the risk of being diagnosed with gynecologic cancer?
In general, no.
Okay.
It's sort of, I guess that's a broad category, but if we think about the, progestin-based therapies, for instance, that we use to maintain fertility in uterine cancer and endometrial cancer, that does not impact, an increased risk of developing ovarian cancer or cervical cancer, et cetera, subsequently.
Okay. Should I work with a fertility specialist alongside my cancer care team?
Absolutely. So I think that's really a key takeaway here. It is so important to be connected with a reproductive endocrinologist, also called a fertility doctor, early on in the process. As I mentioned, you really want to be addressing any of these fertility preservation questions prior to initiating treatment. So while you're doing that workup sort of for the cancer and what the options are, connecting with a group. And I would say the majority of reproductive endocrinology groups are very good about facilitating that. So it's always wonderful if you can work with a group that has experience in oncofertility. So working with with patients who've been diagnosed with cancer. But usually if you express that this is being done in the setting of a cancer diagnosis, that wait time for an appointment will be tailored, right, to get you in before. So most groups are really fantastic with that.
Do providers usually initiate the conversation about fertility, or is it usually on the patient?
Really, the providers should be initiating it.
Mhm.
And just as simple as saying, what are your fertility goals? And for some people that's not going to be a priority, and others it is. And if it is, then sort of going down that route of talking about what could be possible. But I think asking the question in any of any young person who's been diagnosed with cancer is incredibly important.
Yeah. Will fertility sparing treatment affect the chances of cancer recurrence?
So I would say this is the number one question I get asked on this topic. And the short answer is no. The fertility sparing options that we offer in the world of gynecologic cancer, we have good data to support, right? That we are not putting someone at risk in terms of their cancer outcome, we call that oncologic outcome, in order to preserve fertility. So the short answer is no. And I think, I highlighted that a little bit when we talked about cervical cancer. I showed some of that data, but in general, your outcomes are going to be the same as in the non-fertility preserving setting.
Okay. How does pregnancy after fertility sparing treatment affect my health or cancer prognosis?
It, I suppose, depends a little bit on which cancer you had
Mm.
and, what your interval is to pregnancy. But if you've been able to have sort of your full treatment course, 4-year treatment, your intermission, and your oncologist feels it's safe for pregnancy, generally is not going to have impact on your future outcomes. So it shouldn't increase your risk of recurrence. It shouldn't sort of disrupt your surveillance at all. And that's by design, right? We make sure that it's done in a safe way.
I see. How do doctors determine if I'm eligible for fertility sparing treatment for gynecologic cancer?
So we talked a little bit about some of the criteria that we use. Of course, it's this idea of personalized medicine. So you're sort of taking the whole picture into account, but it varies by cancer type, and it varies by sort of medical history in general. But rule of thumb is that early stage cancers in somebody who's young and healthy and doesn't have impaired fertility, that's going to be sort of your big criteria, but that's by no means an encompassing description.
Right. Just a couple more. How soon after fertility sparing treatment can I try to conceive?
That'll again depend on the treatment that you had. So I would say in general, at minimum, it's around 6 months. Classically, it's closer to a year, but it really depends on the treatment.
Are there age limits or considerations for fertility sparing treatments in gyn cancer?
Yeah. So again, that number that often comes up if you look at the sort of published algorithms around this is 40. And that's not a line in the sand per se, right? So I think it really depends on the setting. The most important thing is that you don't want to be doing fertility sparing treatment if there isn't a realistic chance of having future fertility. And so 40 is often used as a cutoff because that's when we tend to see sort of decreasing fertility rates, specifically related to ovarian reserve. So sort of how likely it is that there's going to be a healthy egg that can come from the ovary. That being said, I think there's a lot that can be done to assess that in conjunction with a reproductive endocrinologist, right? Sort of getting a sense of someone's ovarian reserve. And certainly there are many people who say, listen, I froze eggs when I was 25. And, so that's an option, or somebody who would be interested in carrying a pregnancy, but using egg donation. So really it has to be tailored to the individual. But I would say 40 is the line where we start to talk about it a little bit more.
Okay. And the last question we have is, if I have HPV or cervical dysplasia, does that limit my fertility preservation options?
In general, no.
Okay.
So HPV is incredibly common And over 80% of sexually active adults will have had exposure to or an infection with HPV at some point. And that in and of itself does not do anything to impair fertility. Cervical dysplasia is the same. Now, of course, if it's high-grade cervical dysplasia that needs treatment, that's something that has to be looked at prior to attempting fertility. And obviously, HPV-associated cancers are a whole other category. But just, a positive HPV test or a history of abnormal PAPs or biopsies that are abnormal does not, in and of itself, impair fertility.
Okay. Okay. Thank you so much, Dr. Mager, for such an informative presentation. Really appreciated this, and thank you so much for joining us today.
My absolute pleasure. Thank you so much.
Thank you.
Bye.
Bye-bye now.